Okay, so I'll make a start while those are loading up. So welcome everyone again. So this is your site initiation visit for the Lollipop trial, long-term outcomes of lidocaine infusion for post-operative pain. I'm sure you're now pretty familiar with the trial, but just because everyone's got busy schedules and lots of projects on the go, I expect we'll just do a quick refresh of where we are. So this is a trial that's been originated in Australasia. We can't claim any intellectual credit for this. It's come from the Australia New Zealand Clinical Trials Network, led internationally by Thomas Corcoran and Andrew Toner, who I know from my research fellow days back when we were registrars, and he linked with us once the trial was already up and running in Australasia to see if the UK would like to participate and contribute a quarter of the trial participants, which we were keen to do. So it's funded in the UK by the NIHR, sponsored by my trust, UHS, and very ably supported by the trials unit at Bristol Trials Centre. So next slide just refreshes the sort of summary of what the trial is all about. So we're looking at whether lidocaine infusions that patients receive during surgery, and for some patients up to 24 hours, whether that exposure will reduce the incidence of moderate or severe chronic post-surgical pain. And we're interested in that at quite a long follow-up time point of 1 year after surgery. And the patient group, of course, is female patients undergoing elective breast cancer surgery. So next slide, please, which just takes us through the patients that are eligible to participate. So the surgical inclusion criteria are nice and broad. So adult patients, and they can be having either mastectomy or more breast conserving surgery, and the surgery can either be unilateral or bilateral. And it's the primary excision of a confirmed or suspected breast cancer under GA. If it's a recurrence in the same breast, then they're not going to be included. But if they've had some other totally separate diagnosed benign breast condition in that breast which has been operated on more than a couple of years ago, they're fine to be included. We can include patients who are going to be having sort of simple reconstructions at the time of the index operation, so tissue expanders, simple flaps, so sort of perforated flaps, that sort of thing are okay. What we want to avoid are patients who are known to be going on to have much more complex autologous graft procedures, so the DIEP flaps, that sort of thing. If those are scheduled as a definite plan in the months after surgery, then we exclude those. And also, keeping things safe, we just include patients who are ASA 1 to 3. Exclusions really are designed to firstly remove too many confounding variables. So for example, if there's pre-existing pain at the site of surgery, or if this is a second hit operation, then we feel that's too much of a confounder, so they're not included. And then the second thing is really the safety of the infusion. So there's a number of comorbidities and conditions that would affect the metabolism of lidocaine or the cardiac sensitivity to it, and so we exclude those patients with a full list in the protocol. Important note here is that you don't have to do any additional test or screening to find those comorbidities. It's literally just the things that have popped up during the patient's routine pre-assessment. So for example, if you've got a basically young fit patient and it would not be routine to do an ECG on that patient, you don't need to do an ECG just because they're coming to Lollipop. And as long as there's nothing known about them that would create concern, that's not a problem. Okay, any question on the general study overview, inclusion exclusion criteria so far?
No, one of the surgeons was bringing up the concern that there would be whether or not there was some issue with the size of the incision and so on, but that's not part of it at all, is it, essentially, Mark, from what I understand?
No, not really.
I don't know where they got that from.
No, that's certainly not any of the inclusions.
No, indeed.
Obviously, you know, I guess it's relatively standardized surgery in terms of, you know, the intent, but there will be variation in incision size. That's to be expected, and just due to randomizing thousands of patients, we'd expect those differences to equal out between the two groups, really. So yeah.
And likewise, there wasn't any variation of wide sentinel lymph node biopsies and axillary clearance components either, was there?
So
that was just all get included.
Can all include all the auxiliary work? Yeah.
Thank you. Yeah, I did think that was the case.
Great stuff.
Anyone else would say?
No.
Great. Yeah.
Perfect. Okay, next slide, please. Okay, so a little run through of the study flowchart. There's a little bit there that separates intraoperative or intraoperative and postoperative patients. So I know your site, like us and many others, will just be concentrating on day case patients. Something we can review in the future, but certainly for now, I think most UK sites are focusing on day cases. With that in mind, the green bits really sort of take you through patient approach, screening, patient identification and consent. The protocol is quite broadly written so that patients can be contacted by a variety of means, telephone, they can have consent forms posted out if that suits them. Obviously, using any opportunities for face-to-face contact you can find. Quite an important thing, I would say, is to make sure really all the sort of the thinking, the decision-making process is done before the patient attends for surgery. There's nothing stopping you from actually physically getting a signature on the consent form on the morning of surgery. But what we want to avoid, and we have had some feedback from our local site that occasionally it's been felt that the conversations have been a bit sort of preliminary and there hasn't really been a decision made, and so the patient feels like they're having to make a decision on the day of surgery. So really try to get them away from that, try and get them doing the thinking and thinking about whether it's a yes, no, or have I got any questions before the day of surgery, perhaps with a follow-up call as well. And then you can either post out the consent form or you can get them to consent on the day of, but really try and avoid any sort of substantial decision making happening at that time when they're stressed. In terms of once they are recruited, so they're randomized, they have to be randomized on the day of surgery. That's to avoid sort of potential wastage of ampules and that sort of thing, and also sort of the timing of follow-up and so on. But essentially, after that's done, you get some baseline data, and then prepare the intraoperative infusion, and then work with the anaesthetist in checking that, and then they administer it after induction of anaesthesia. So the infusion runs all the way during the case, assuming there's not been a reason to stop it. It goes with them into the recovery area, where they have some ECG monitoring and they have their lidocaine safety tool administered to make sure they're not getting any early toxicity symptoms. And then once they're ready to leave the recovery area, they have the infusion stopped and they carry on just on a normal clinical pathway. No need to delay their process, no need to delay them in recovery if they're ready clinically to leave recovery and get back to the day unit or the ward. And then after that, there's a bit of data to collect from the intraoperative phase. I'm told by our nurses that's a really good time to do it when the patient's in recovery, because you know, they'll have the anaesthetic charts there. They can have any queries about illegible writing and so on, make sure they've totaled up their remifentanil, all that sort of thing. And then basically once they've gone, post-discharge, the follow-up becomes very easy. So anything, excuse me, that is patient reported just gets done automatically through our centralized system. So the patient will get an automated alert and they'll have a link to a sort of anonymous study database they can log into and put in their responses to the questions. So your team don't have to be doing lots of phone calls to track people down, finding time for them to do the questionnaires and so on. It really is nice and slick. One of the time points has got, two of the time points have got a brief medical notes review needed to see if they've had any other cancer treatments and so on. But the patient side of things is very, very straightforward. The only ones will just alert you if they haven't responded to prompts to log in and do their patient reported outcomes. We will ask you to make contact with those patients, but otherwise we hope that the vast majority will just do their own, making the sort of post-discharge follow-up as easy as possible for you.
Can I ask something quickly? Is that okay, Mark?
Yeah, go for it.
When I was looking at the trial process, you did mention that it's quite important to get that primary endpoint 1 year, and sometimes actually a phone call at that point is quite important. So that's one thing. And have you found that that's something that we trial centres are having to do quite a lot of? Secondly, have you found this to be a success in integrating this with the breast care nursing groups in the various different trial centres? Because I've been trying to build a relationship with them, and often they get a lot of interaction with breast care nurses. I was wondering whether or not that's something which you found in other centres or where you're doing there in Southampton, that by having that dual tandem following up with it, you actually get increased response rates back from these women.
Great stuff. So on the 1 year thing, you're absolutely right that the 1 year time point is really critical. That's the primary outcome of the trial. So no data equals no trial result. So that's really important. We're yet to get to the 1 year time point with any UK patients. Just opened in October. So, but we are now starting obviously to do the 3 month stuff. I think, Chloe, remind me, have we had some, I'm trying to remember if there's patient-reported stuff at 3 months or not, but have we had uptake from patients, and do you know how much chasing we've had to do as a rough back-of-the-envelope percentage, would you say?
I'm not totally sure on the chasing, but we've had a good sort of response rate. We've got quite, I think we're in the 90s for completion of 3-month questionnaires, and a lot of that is through the electronic system.
Oh, brilliant.
I think it's a bit hard to compare with the Australian patients, because all their follow-ups are done via phone, and we just thought that wouldn't be feasible in the UK, getting research teams to complete questionnaires over the phone. So that's why we opted for the electronic completion, and so far I'd say it's proven successful. But yeah, off the top of my head, sorry, I don't know the data about how many have been chased.
In terms of sort of integrating follow-up, as I say, as we've sort of described, there's not a huge amount that needs to be done by the sort of the local research team. So in general terms, absolutely welcome the idea of integrating with breast care nurses, and I think you'll find that the team will generally be sort of working alongside them in terms of, is the patient on other trials, when patient support is needed, that sort of thing. They're definitely a good group to form a relationship with, absolutely. But in terms of the follow-up, really it's sort of that electronic stuff, that online stuff, automated, and then really it's just a notes review. So yeah, it really is quite straightforward. But yeah, generally, if there's opportunities for collaborating with breast care nurses, then yeah, go for it, absolutely.
We might be in the situation when a patient is lost for follow-up, and then you will ask us to tell you a few things about that patient at 3 months and 6 months, and in that case, liaising with the breast team would be really, really useful, because they will do their follow-ups. They will come for the surgical follow-ups.
Yeah,
that might not answer your question as well.
Yeah, no, I mean, I think if there's any hint that you're struggling to get information from a patient, then yeah, I mean, you could potentially touch base with the breast care nurses and just see if there's any events that have happened that's getting in the way of them interacting. Yeah. Absolutely.
Thanks. Okay, yeah, that's useful, because some of our patient population here have a bit of data poverty, sort of in technological poverty and so on. So that getting the database, I'm not trying to propose that is the case, but it's certainly something worth keeping in mind for us up here. Okay, thanks.
Great stuff.
Can I just
Sorry, go on, Faye.
Sorry, can I just add to that point? So there is an option, you can complete the questionnaires over the phone with them if your patients had a phone. So that we do have both options. The idea with the electronic one was just to take the burden off you a little bit, but there is the option. Yeah.
Yeah, thanks. That's great.
Okay, I think next slide, and I might be handing over for a bit.
Yeah, thanks, Mark. So I forgot to say, sorry, at the start, that this SOV is kind of based on the assumption you've watched the training video. So if we don't go into enough detail about something, please feel free to ask us to expand on things. But yeah, so just a little trial update. So the study is open in Australia, New Zealand, Hong Kong, and the UK. So 16 sites in Australia, 3 in New Zealand, 3 in Hong Kong, and we've got 7 open at the moment in the UK. Overall, there's been 1,063 patients recruited to the trial internationally, and 63 of those have been from the UK. I also can't see anyone as well, so if you do have any questions, please just shout out. So yeah, assuming you've watched the sort of screening, consenting and randomization videos, we're just going to have a bit of a discussion about how things are going to work at your site, or how you see them working at your site. So could you sort of just run through with us how, sort of who's going to be identifying patients, and sort of how and when they're going to be approached, and who will be doing that approach?
Yeah, so the current flow map is that here at this trust, patients go to with a breast care group. They go through a sort of triple clinic where they get their investigations and so on, and then they go to surgical clinic fairly soon afterwards, post MDT, to have a discussion about what they're having, and then thereafterwards they go to a subsequent clinic again a week later where they have a consent clinic, and they go through the pre-op process after that, and then are listed. So I mean, the identity of patients, we're quite hopeful, is going to be happening in the surgical clinic, where they'll be giving information leaflets, the patient information leaflet, to these patients. I'm mindful that doesn't lead to inclusion exclusion criteria sort of granularity, and so I wanted to know whether or not you feel as though that would be inappropriate, just distributing to all patients, because I'm not too sure whether or not we can really be relying on the breast care nurses and the surgeons really to be differentiating, particularly in quick clinics. But I suspect that's where we're going to see the majority of patients picked up. We will know from the MDT. We'll be able to access to find out what patients are listed. So we should be able to be getting CC'd spreadsheets, I'm hoping, about which groups are there. So we can then, as a group, follow that up and start trying to contact in due course. And my understanding is that you work quite closely next to that breast clinic, don't you, sometimes, Alina, during the week? So hopefully we'll physically, physically in close proximity. So, but this has been something I have been deliberating a bit about. I'm also mindful that on the actual day of their diagnosis, these women may not want to necessarily have that put upon them and the discussion about the complex discussion. But we are lucky that there is a consent clinic, which tends to happen a week later. So I'm hopeful information can be provided then, and then we can follow up with the women at the consent clinic to see whether or not they do want to then go through a secondary consultation about recruitment and checking for eligibility in the trial here.
Or we can do remote consent.
Yeah, or do a remote. Does that give some information?
Yeah, that sounds good to me. Yeah, thank you.
Yeah, I think that sounds really good. And I think, you can be providing very outline information at the early stage. So, I mean, we encourage our surgeons to just mention it as a possible thing and indicate the poster in clinic. They are, they do have reservations about it. I think, there's definitely a understanding that once the news has been broken, there's a lot of information to take on board. Our team actually have just one single listing clinic. So it's diagnosis and sorry, you need surgery. And that's actually the last surgical contact until the day of surgery, although they do have other bits, including the pre-assessment. So we sort of have to work around a little bit. And I guess they're less keen to sort of go into too many trial details at that point. It's more general information, really. But it sounds like you might have another contact opportunity. Which
I think so. From when I was talking to the breast care lead nurse, that happens often. And I think that might be a useful window for us. I mean, ideally, we'd be able to identify the patients from the MDT even before the patient knows. So we, when we approach until after they get the diagnosis, clearly. But I think about information leaflets is fine. There is a standardised information leaflet which we can issue out, is there not? So I think we're just going to have piles of that. And my intention is to get the breast care nurses to be quite proactive, suggesting about this. It's just as not to give to anyone, but here's some information about a study that's happening in this trust, which you may be eligible for. I think that's really important because then the patients had some opportunity for information prior to meeting Elena, probably myself in advance for that. I think that's the interesting. Obviously, stuff will get dropped along the way, and then we'll try and catch it from keeping a sort of routine look at the spreadsheet of who people have been approached from the MDT discussion. That's my thought of what happened weekly.
Yeah, that sounds good. Sounds good.
Great.
Sorry, did anyone else have any other points? Sorry to answer that. Yeah.
Fab. So then, sorry, didn't know if that's someone trying to talk. So can you then run through your plan for sort of the day of surgery and how you see randomization working? Obviously, like you need to get the IMP and things like that.
Yeah, this is going to be tight. I think it's probably fair to say. We've already looked at what's happened so far in our centre. The majority of this workload is done first on the list, and I'm pretty sure I suppose that happens elsewhere quite commonly too. And our list probably starts, and the anaesthetic starts at 9:45-ish of that order. So what will happen is that we will be intending to identify who the anaesthetist and surgeon is in advance and contacting and ensuring that they are happy to proceed. I think that's also a useful opportunity to double check that they have any questions about how the protocol works and like an educational process whilst the trial is just starting. We will then, a member of the staff, primarily probably yourself, Elena, will be there in advance of the surgeon and anaesthetist consulting the patient on the day to clarify that their consent's been done, written consent, and also they are happy to still proceed. And then just double check with the anaesthetist or the surgeon if there's been any change of staffing that they're happy to proceed, and then randomise there. We're assuming in the best of worlds that will take approximately 20 minutes. So the process there, I'm saying, is at kind of 8 o'clock to 8:20 would have that. Lisa's very kindly been quite proactive in trying to figure out how we can get the dispensing process done very efficiently. And so the dispensing form as issued when completed by whoever's doing it, Alina primarily, after randomization, will then be sent through to there. We're approximating it's going to be about 15 to 20 minutes for getting drug dispensed. So we're mindful 30 minutes, half 40 minutes before getting the drug back up to the theatre, which we're hoping will then be prompt enough so that once the patient is kind of coming into the anaesthetic room, cannula has been formed, we can just double check that they need just to draw up the syringe, and then they are ready to then give it through on the day. The only concern I have about that is it misses the opportunity to ensure, remember, the trial team is there available at brief, talk with the team to ensure they're all happy with that. I think these are one of these fine niceties which we're probably going to have to grasp. And I think it also might be one of these things where we've had a little discussion this morning with Lisa that it might be that we'll be able to have the dispensing sheet forwarded through by email and PDF to the pharmacy team, so that bit can be started be processing. Elena can be in attendance with the team briefly or something like that to just double check the team are ready and happy, and then we'll go down and get the drug and bring it back up in time. So that's the rough way I would see of the process of consent, double checking, randomization, and proceeding with getting the drug dispensed and drawn up.
Okay, great.
Does that
Thank
answer
you.
your question?
Yeah.
Yeah, please, sorry, the rest of the team, please jump in.
No, that's what we discussed. That sounds fine. Yeah.
This is our plan. If you see any.
Yeah, we're all in this. There's better ways of doing it.
Yes, yeah, all sounds great, and sounds like you've thought through it all. Just one question I was going to ask is your plan to store the IMP in pharmacy? Because you don't actually have to.
No,
which can help with the timings.
So we have Joe, the lead pharmacist, has already put an application for another trial to have a thermal neutral fridge apply for. We don't have that at this trust yet, but we are going to piggyback on that so that in due course, 6 months or whatever time we get the grant for it, we may then be able to have an area or such point of storage which is closer to point. I think we'll have to cross that bridge when we get to it. At the moment, our current process is going to be one of it being stored in pharmacy, so we're just trying to make sure that's optimally set up for speed and governance for delivery. But we will approach that, and I think I'll liaise with you when we know we've got that equipment.
Yep, fab, thank you. Okay, so next discussion point is, so this wouldn't be, obviously, to start with, we wouldn't recommend having 2 participants on the same list while you're getting familiar, but sort of for in the future, when you're feeling familiar with the trial, have you thought about the potential of having 2 lollipop participants on the same list?
We have, yeah, totally. I think our issue will be probably the similar issues that other people have, which are having an extra pump, because it might be, let's say, for instance, there's some issue with the list criteria of that pump being in one patient, or if we're doing back-to-back patients, we'll need a separate device, which I believe you guys issue from your side, from yourselves, don't you? And then secondly is just making sure there is enough team availability, because otherwise it's quite a lot of workload for the research team to be there. So I would be delighted if we can do that. I suspect we probably would have the population and surgical list where we could possibly manage that, but I don't believe we are in a current position to entertain that at the moment. I think it'd be important to get a consistency of making sure we reach the recruitment numbers with the current 1 patient only list. And I'm imagining we have lists 3 times a week, so I'm hopeful that we are going to be able to see evidence that there might be opportunity in the future for double up.
Yeah.
Does that answer your question a bit? And the rest of the team, sorry.
I've got one question about randomization.
Yeah.
Will the whole team, whoever is on the delegation, will receive an email about a randomization taking place?
Yeah.
Okay, thank you.
And that will be via your portal, presumably.
Yeah, so whoever has an account on the database, it will notify you. You'll get an email that says study ID.
Yeah, I might ask us. Yeah, okay. I might ask you. Do you have any on that database for that email account? Do you have any of the trial centres where they have a generic local email address for that trial, so that it gets pinged to a groups to make sure that it's not lost to any individual person? It goes into a reservoir of kind of email accounts for that big group. No, I'm just checking. Does that happen amongst any of your centres?
I'm not sure it does on the main trial database. I can ask, so the Australian team sort of built the main database, so I can ask them if it's a possibility. I'm not sure we've got it with anyone
No,
at the
the
moment.
only
But
reason
I
why I
can
asked-
ask.
Because personal email addresses, I mean, we should be doing good due diligence to check it, but I do find group email addresses sometimes are quite a useful redundancy or backdrop to make sure that somebody then looks at it and makes sure that's been checked for. But I'm just asking whether or not that is or isn't done.
I've written down to check, so I'll find that out and I'll let you know post SIV if that's okay.
Sorry, ladies, do you have any questions?
Sorry, I think we may have checked this before with the team, and I don't think we are letting people register on the database with a group email just because we
Fine.
need that kind of audit trail if anyone's doing anything on the database. But it will go to every person in the team who is on the database, so
Perfect.
it shouldn't get missed, if that makes sense.
No, I understand. Thank you.
Yeah.
That's helpful information. It's just me being pedantic
No,
about stuff.
it's a reasonable question.
Great, thanks, Leah. Just so obviously, as you've said, this wouldn't be something to think about initially, and you might not, if you're recruiting, you might not even need to think about it. But if you did ever want to recruit two on the same list, just a couple of points we sort of suggest to sites that might help in that situation is, if you do have sort of that good communication with the theatre list coordinator, and you know the lists ahead of time, perhaps like working with the coordinator to plan that there's a non-lollipop patient in between two patients, or Mark might have to jump in on this, but I think when the patient goes into recovery, you can then switch to one of your normal clinical pumps to do the final mils per hour infusion.
Okay, I didn't know that.
So
my mistake.
yeah,
I should have looked at the protocol.
no,
Can I
sorry,
just say that-
that's not written in the protocol. That's some advice the Australian team have given us.
Okay. All right.
So I don't know if Mark wants to jump in on that at all.
Sorry.
Yeah, no, just that really. I mean, the cleverness of the pump is that it takes care of the bolus and then automatically goes onto an infusion and just makes everything nice and neat and tidy. But basically, from the point of infusion onwards, it's literally just acting as a very simple mils per hour pump. So you can briefly pause it at the end of theatre, pop it on a standard syringe infusion pump at the same mils per hour rate. You could always just do a quick double check with the anaesthetist and research team, say, right, yep, that's 3 mils an hour, on it goes. And yeah, you just carry on like that. And the briefing is certainly not.
So that's what you've been doing rather than.
And then you can basically recycle the pump ready for the next one.
And of course, it won't be seen as a discontinuation of the infusion.
No. Brief discontinuation like that is absolutely fine.
And that's that's how it is achieved in centres which are recruiting.
Yeah, the Aussies are doing that. Again, I don't think there's a lot of people having multiple patients on lists a lot, because it is a lot of work. By the time you've randomised, got baseline data for more than one patient, it's quite a lot to do. But if you're having a quiet week and you just happen to have two great patients who are on the same list, it's kind of a shame to lose them, isn't it?
No, indeed. I think I'm thinking more politically and getting the stuff going. I think that's probably the important way. We are going to be a member of the team is one of the sort of more senior ODPs in the department, and so we're going to try and have a footprint in the listing meeting so we can try and achieve that. We're quite a small centre, so we can probably, we're going to already be looking at that. We need to sort of do that so we can ensure that there's adequate information in advance for the pharmacy team to know in advance when they need to be available.
And this was
anything else from the rest of the team?
No.
Yeah, that's it.
As Chloe said, I think park it for a little while. Just focus on getting one patient list through in the immediate future, and then if you are flying and things are feeling pretty slick, that's the time to think about more than one patient, I think. So yeah, obviously get yourself going first.
Fab, thank you. And then obviously this trial needs support from anaesthetists, surgeons, recovery nurses. Just sort of to check, have you sort of had those discussions with the various teams at your site? Have you got support? We've got some training materials we can supply to you to cover with those teams. So yeah, just how's that been going?
Brief heads up, the trial, the anaesthetists who are regularly on the breast lists or have been aware, I've made them a local presentation and video for that. The surgeons, there's only a couple of them, and I've presented about it at the breast care nursing group post MTT. Recovery haven't yet, but the intention is that at the local audit meeting, which will be up in the next couple of weeks, we will be doing that. So all resources would be very valuable. I was going to wait. I'm relatively junior. This is my first PI role for this as a consultant. And so I wanted to get your information first, post SIV, and then start accelerating it the next month or so of training people. And I'm also mindful of the group meeting that we had, well, prior to Easter now, wasn't it? There was a lot of conversation that it's quite important to make sure there's targeted training for people, like focusing on sometimes individuals rather than just brief, broad swathes. So we'll be doing a bit of that, but also making sure that individuals on the day have some targeted training in advance to make sure they're doubly checked and up to speed. Pharmacy, obviously Lisa and Joe are up there. I don't know if you've disseminated amongst the pharmacy group particularly yet.
No, we tend to do that a bit later on when we're a bit closer. Obviously all of our top trial team are aware of the trial and know what they're doing with it. I have reached out to Scott, who's one of the pharmacists who works in theatre, who sometimes covers theatre. So I have spoken to him about it, and I've given him some information about, and I've given him the training.
Maya's one of the residents here, so she's kindly taken on the role of API, so obviously doing your training side of things, and we'll no doubt announcing it to the residents at some point as well, because they'll be a tribute to the team, and hopefully they'll be quite proactive in trying to support it, and just having more people on the delegation log to be able to help with drawing the infusions and so on. So no, we've done some. Our intention is to do a lot more.
For recovery, the plan, my plan for the moment is to follow that patient throughout the journey, but the parent, particularly for recovery and for discharge, because we are only doing day cases, I think it would be safe for the moment to be followed up by me together with the recovery nurse. For at least for the first cases, to figure out what training needs we have. We might not need to train the recovery staff too much if it's not something.
I think from what I read, and I'm sure it's been stated, my concern is at the recovery point. I think once this, as in I know from when there was that group meeting, there was quite important to ensure that there's a baseline understanding of what the symptoms are for that patient, so that they're not. We're not applying on the list criteria immediately for cessation, because I think anything new can sometimes be a bit worrying for the recovery team, and there would be an intention to stop the infusions very rapidly. Whereas I think with some support and understanding and ensuring that it's really clear that they're meeting those criteria, and then obviously they would stop it, then I think that we won't lose too much. Is that something which you would advocate?
Yeah, and we've got slide set we can provide you for recovery. It's a slide set that Mark uses at his site, and he's kindly let us have it to share amongst teams.
Could we have it for all of the groups? I would be very grateful for any surgeons in recovery. I'd be grateful if you're happy to have that permission.
And just we'll probably cover it a little bit later in the SRE, but just to note, so not all anaesthetists need to be on the delegation log. So if if they're going to be more involved in the research, prescribing, and so I'm having a bit of a brain freeze, signing off SEs, things like that. Obviously they need to be, but if they are sort of not going to get more involved than just being the attending anaesthetist on a lollipop patient, they don't necessarily need to be on the delegation log.
That's helpful.
So so different levels of involvement in the trial, they don't all need to be on the delegation log. Depends on.
That was a question I was going to bring up, because I'm mindful of two things. One, they have to enter data potentially, which contemporaneous data. Are they presumably they do have to be if they're going to be editing the CRF?
Again, I might call to Mark to jump in, just having sort of that hands-on experience. But my understanding is it tends to be the research nurses filling that in, and they kind of get the information from notes. I don't think there's much more that wouldn't be recorded in the notes. One of the is it remifentanil, Mark? One of the drugs isn't necessarily always recorded.
No.
So you need to sort of be mindful to ask the anaesthetist to note down that, but as far as I'm aware, there's not too much that wouldn't be recorded.
Would you not find it more useful having them doing it so that they can then enter the data, so there's less work for the poor research nurse to be entering all the interoperative data? Because my thought that's one of the reasons why we'd have to. And then secondly was that they'd have to make some consideration about interpreting whether or not an adverse event is or isn't not needing infusion cessation. which I thought again would require delegation log statement. Although in fairness, I guess they can just follow the protocol. But you know, this is where I'm a little uncertain about. I'm a bit surprised. I thought you'd expect them to be on the delegation log. Well, that's my mistake.
No, it's fine. So I think, I mean, the general overriding concept is that if people in research are doing things that, you know, they might be exposed to doing in part of their normal clinical role, then they don't necessarily have to be GCP trained on the delegation log.
Okay.
And that's certainly the case here. You're right that, you know, if they're getting into the CRF, then they should, you know, be on the delegation log. The way we run it here, though, is basically to have, I mean, really the only anaesthetists on the delegation log at our place are me and the APIs.
Okay.
The reason for us being on the delegation log is basically to be able to sign off eligibility, double check eligibility, make sure the patients can go in, and to prescribe the IMP on our hospital prescribing system. Apart from that, the research team run it. And I think the idea is really that, you know, a breast case list, it's a fair bit for an anaesthetist to do. You know, they're often fairly high turnover. You know, they're thinking about, you know, providing care to that patient. We felt, and I think the Aussies tend to feel as well, you know, we need to facilitate that. We need to get clinician support. We need to make them feel they're not being overburdened. So it's a case of, yeah, the research team have set up the infusion for them to check. The research team are doing data collection. I think it could be quite off-putting for intraoperative anaesthetists if we came to them saying, can you support this patient through the trial? Here's a load of extra data you'll have to fill in.
Right.
You have to draw up the infusion yourself. I think you start to potentially see little bits of hesitancy or refusals kicking in.
Okay.
And so really, we really sort of do it as a sort of research team driven thing.
Okay.
And with that sort of collaboration, it does seem to work out pretty well. As I said before, a lot of the intraoperative data can be done by the research nurses while they're in that sort of post-operative phase in the recovery ward.
Okay.
They're sort of keeping an eye on the patient, working with the recovery team, getting the CRFs up to date. And they can put any queries back to the anaesthetist, but effectively they're leading that process.
Okay.
And we found actually our clinician buy-in has been brilliant.
Thank you. Thanks.
The system works pretty well.
About prescription. They also prescribe it on their online system.
Oh, yeah.
We'll bring that to pharmacy.
Yeah.
Thanks. You just brought something up which we'll bring up in the pharmacy section as well. Okay, that's helpful. The reason why the Liverpool team disseminated a few bits of documents of their local stuff, and it had a interoperative data collection form, which I thought they'd be asking their anaesthetists to do, but presumably actually what's happening is the research nurse is commonly doing that in, as you described, post-operative. So that's helpful. Thank you.
Yeah, I mean, the only other thing they might be doing is if, you know, to make it easier for research nurses, they might be asking the anaesthetist just to clarify certain aspects, just in case their forms are a bit hard to interpret. I mean, the classic one, as Chloe said, is the remifentanil dose. You know, the Teva pumps don't give you they will give you a total amount of remifentanil infused, but once that's been switched off, that's it. The information's gone forever, and you can't engineer the calculation. So that sort of thing, you know, if they're finding there's data points that are tricky, they can actually just say to the anaesthetist, look, can you just write down these 3 things because it's hard to get from your chart.
Okay, that's helpful. Do you have any questions, John?
No.
Great, thank you. And then last discussion point is just, have you had a chance to use the staging database, which is a test database that it looks exactly the same as the main database? And do you have any questions at all?
My honest assessment, I haven't yet had a lot, and I'm not sure the rest of the trial team. We will do. I was kind of awaiting for the SIP, but we'll have a little bit look further than that, and I'll forward any questions. It looked from the training videos, it's a relatively straightforward database to use. So.
Just to say, if you haven't activated your accounts, the link does expire. So
I've already done that with you. I managed to not do it right, and then I think you've activated it for me. But it might be that the rest of the group who will need access, or they can use mine, I guess. But yes, I've activated mine. So.
When was that access sent out? Because I don't recall seeing anything.
Could have been a while ago.
I think it was in late March, early April.
Early April, late March. I've seen that everything.
I'll double check. I might have to re-request one.
Yeah, I think
I don't recall seeing it, but maybe I've missed it.
And can I clarify? Sorry, just to advocate, because I think Maya's only just been agreed. Can we ensure that Maya's linked into that email for that, please? If that's okay. I think I forwarded that. Well, it might be worth. I believe I forwarded it, but it might be worth double checking as a job. Okay.
Yeah, great. I think that's all on there. So I'm going to hand back to Mark for a couple of slides.
Thanks very much. So just to really highlight, I'm sure you've seen this dispensing sheet. It's quite central to the care on the day of surgery. So essentially, it's generated once a patient has had their information entered, which will include their height and weight, so that the database can calculate their lean body weight. And once they've been randomized as well, this dispensing sheet will be produced, and you should print that out and use it as your sort of a bit of a guidance. You can see there's patient details there, the vial number that will be checked with pharmacy, and this tends to be the thing that you would take to pharmacy to say, right, this has been requested, is this the thing you can now dispense? And there's a couple of sign-offs. One is when the vial comes out and is dispensed, so a research team member, and then a second person countersigns having checked the vial code and expiry date and identification. And then the second bit of cross-checking is once the pump has been set up by the research team member, the anaesthetist can then just double-check the settings on there to make sure it tallies. Now, as I mentioned before, the pump is set up based on lean body weight. We'll take you through the pump in a little bit, but essentially it will then give you some numbers to cross-check, which will correlate with the numbers on this form, and you just need to make sure they match. What I would say is that there seems to be a slight rounding difference in the way the pump does its calculations, the way the database does its calculations. If you see a 0.1 mil per hour discrepancy between the pump and the dispensing sheet for the bolus rate, that is actually okay. It's just the way they round differently, and I'm sure you can do the calculations and work out that it's completely clinically irrelevant in terms of how quickly the bolus is being given or how much bolus is being given. It's a non-significant difference. So do please sign that off if you see it, but the eagle-eyed amongst you might come across that now and again. The other thing that's on here that's really useful is this blue box here. As you know, other local anaesthetics can be given in addition to the trial infusion, either for infiltration or for regional blocks. And the caveat with that is that we just put a dose limit on to maintain safety in terms of total local anaesthetic dosage. And it gives you some suggestions there for that patient, bearing in mind their body weight. It just gives you some suggestions there. So it's quite useful to have that at team brief, for example. You can be saying, here we are, we've got this patient. Are you going to do a block or are you going to do infiltration? If so, here's the total dose of alternative local anaesthetic that you can use.
Can I just mention something? Is that okay?
Yeah, of course.
With this dispensing sheet, we were going to be moving quite swiftly. From memory, you said you needed some patient identification details.
Yes. Yeah.
What I'm mindful of, you don't want to have patient identified data from a purpose of government's point of view of the trial. This will have to then stay with the CRF, I'm assuming. Is that correct?
Not necessarily. I mean, you could probably take.
We would have a separate. We would need a separate one though. So you would keep yours.
So we'd probably have a copy without a patient
details. Two of them, one with
so we can treat that as almost as a prescription. I know it's not a prescription per se, but with that, so we'll treat it and then we'll keep our copy in the pharmacy file and we'll file it. So we've got a record of our. Yeah. So yours will be separate.
I think we might revisit that when we're talking about how do you prescribe locally, if that's okay.
Yeah, and as I say, in most cases, in all cases, we also expect there to be a hospital-based prescription as well on whatever normal clinical prescription system you'd use. So, for example, we've got an electronic system at our place, and the team set up just a simple template for that, which says lollipop trial, lidocaine 2% or saline placebo, and that's what we sign up as the IMP, and that's what gets signed when it's being given, just so there's a hospital audit trail of, this patient was given something, which might have been one of these two things. In terms of getting the drug from trial pharmacy, they're going to be checking out the vial number, so they're going to need to see this dispensing sheet so they can make sure that the vial number is correct.
Can I clarify then, because it's been brought up? Does every trust follow that it does it on their online prescription? My reason for asking is there are certain drugs which we administer intraoperatively here, which we just document on the anaesthetic chart, which we wouldn't document on our online prescription, a dose of fentanyl or something like that. Is it felt that it is important from a government's point of view that this trial drug needs to be prescribed in a way that's time-stamped, other than just being on the anaesthetic chart?
Generally, yeah. I mean, in fairness, the protocol doesn't specify this particularly strictly. So I would say do what you would normally do in your trust. I do know that, for example, if we're giving any drugs which continue into the recovery period, we always have a prescription sheet foisted at us by the recovery nurses. Write down your noradrenaline, otherwise I'm not carrying. I'm not. We're asking the recovery nurses to continue to administer a drug started. And in that context, in my place, yes, they do expect a prescription to be there for it.
Okay.
But your place might be different. I don't know. If infusions that are started intraoperatively and carry on into recovery aren't needed to be prescribed, then that might be okay.
Because I discussed it with one of the patient leads, safety leads, as one fellow anaesthetist, and I was trying to think about what was the simplest and most streamlined way of doing it. And essentially, some things on anaesthetic charts seemed acceptable, but I think we'll revisit that then and maybe try and set up an order set on our local prescribing online as a job to do. I don't think it'll take too long to set up, but it was a step which I had uncertainty about, and I made a judgment call, and I'm glad we discussed it. So I'll put it as something for us to do. Okay,
that sounds good.
Thanks. And a final point of clarification, from memory, when we're inputting this data onto the intraoperative drug dispensing sheets, it will then calculate the lean body weight. Is that correct? Yeah, it does. So that answers your question.
Yeah, does it for you, yeah.
Yeah, so you just add in the actual and the height, and then that's fine. Great.
Yeah. Good stuff. Okay, next slide. So we'll be giving you the Alaris Nexus pump. Very straightforward to use. Do you have these in clinical use anyway for TIVA?
We do, yes.
The PK.
I can't necessarily remember if it is the Nexus. I believe it is, isn't it? Because that's the one which has the TIVA algorithms associated with it, which is actually, I guess, probably a problem rather than a benefit, because it might be that people will let this whiz around. So we're having to think quite tightly about how to keep this particular pump safe from prying hands. Yeah, so when they get supplied to you from us, they'll have lots of stickers on them that say that they're just for the Lollipop trial. There's a sticker on there which basically reminds you to only program in lean body weight. And actually the pump has been reprogrammed, so it does not have any of the anaesthetic models within it anymore. Yeah.
So the only two accessible models are meals per hour or the Lollipop protocol. And obviously when you're setting it up, you select the Lollipop protocol. All you then need to program in is the patient's lean body weight, and it will then generate some expected numbers for the bolus and the infusion. At that state, if you just pause setup, because that's what the research nurse will need to show to the anaesthetist to say, look, this is what we're expecting to give. That's the point at which you check together, countersign the dispensing sheet. You can load the syringe in before that or after it. Yeah, some of the Australian training videos mentioned going through the whole setup phase and then going back to review the settings. The Nexus, for some reason, doesn't allow you to go back to see the detailed information once you've actually confirmed the settings. So you just have to pause as soon as you put in the lean body weight, and it won't alarm. It'll just sit there quietly until you're ready to show it to the anaesthetist, basically. Obviously, the pumps are being funneled through Southampton. Our medical engineers have put the correct program on. They've done some checking. We assume that all sites will want to sort of onboard new equipment through their just sort of safety checking through the medical engineering team, and so that's fine. And obviously a case of the research team, as you mentioned, if you've got some of these pumps around already, it's really important to take it back at the end of the case, keep it safe and away from the clinical circulation, and charged up and ready to go, basically.
Okay.
Question that I made before. The checks, the pump gets checked periodically, or we just use it after we receive it?
So it's got a 3-year maintenance cycle.
Okay.
So it could be, if we do well with recruitment, you don't actually need to get it maintained during the time. They're very robust. They very rarely throw any faults. So it'll have been checked already. Your medical engineers will probably want to do a quick check on it as well. That should be good for 3 years, basically. And if we are still recruiting at 3 years, then we'll bring it back to Southampton to do a maintenance service and recheck.
Thank you. Can I clarify, just because you brought it up? If we are, say, for instance, now shifting into a different pump in recovery to going back into mils per hour and then using the Nexus pump for a further case, does it matter what pump you use to maintain that mils per hour infusion? Does that have to be a Nexus as well?
No, anything.
It could be any pump as long as it's delivering in accordance with protocol.
And in fact, you might almost argue it's better off being on a dumb pump so that nobody can accidentally pretend it's an IV anaesthetic or something.
Yeah. Okay.
So I would actually advocate the simplest possible syringe infusion pump without any special models.
That's helpful. Okay.
Would it be useful to record like a serial number for the pump or something like this? If just in case.
Well, locally, presumably, as in that it has a serial code on it. Presumably, the pump we're going to be issued like all pumps.
Yeah, and we the Southampton engineers have got a database of which serial pump numbers have gone where. So it'll be tracked.
Yeah. Go on.
Any system that they move planning so that they've confirmed it on the pump. I know the dose thing that goes into the IFRF. Just confirm they don't need the examination logger, even though it's going into the information pack.
Sorry, I'm struggling to hear
You might speak up one.
exactly what you said. Just a little bit. Sorry.
There's an anaesthetist who checks the dose and then signs on the sheet to say that they have checked the doses against the
With the research nurse.
with the researcher. Their signature is then going to go into the patient pack. So just to confirm they don't need the examination log.
Correct. Yeah.
Okay.
Yeah.
Because it's just as if, again, let's say you're on intensive care and say to an ICU nurse, oh, we need to start some NORAD for this patient, or we need to start some web treatment. They might say, okay, I'll go and draw it up. They draw it up. They show you what they've done, double check the drug. So yeah, it's within your clinical expertise. So yeah.
Yes. Yeah. Okay. Anything else from the rest of you guys? Thanks, great.
Great, thanks. Back over to me now to run through some safety bits. Thank you, Mark. So on the screen now you can sort of see a summary of the study drug infusion stopping criteria. So this is found within the protocol, but we'll also provide you in your startup pack that we'll post out to you a printed copy of this, and just to say that it should be kept with the patient at all times whilst the study drug's being administered. So yeah, just runs through when you should cease the infusion at different times. And then moving on to the lidocaine infusion surveillance tool, or the LIST. So this tool is intended as a rapid aid to identify clinical signs or symptoms that may indicate the patient starting to develop lidocaine toxicity and will mean you have to stop the infusion. So the tool asks 5 symptom questions and assesses 7 clinical signs. So for day case participants, you should start completing the tool in PACU or recovery within 15 minutes of the participant's arrival, or when the patient is sort of awake enough to have a conversation with you. And then you would again ask the 5 questions once the patient meets the criteria for step down to reduce monitoring, so sort of when they leave recovery. If at any time the participant answers yes to 2 or more of the symptom questions, or they have any signs or complications, then you must stop the infusion. After you've stopped that infusion, if the patient is sort of otherwise stable, you should repeat the list tool hourly until all the symptoms and signs have resolved, or 2 hours have passed, whichever comes first. Yeah, that's the process there. If the patient is unstable, you should initiate rapid or urgent review by anaesthetist or the theatre emergency critical care team, however that works at your site. And make sure the person reviewing the patient knows that this is a lollipop participant and may have had lidocaine, so may be experiencing lidocaine toxicity. If it is suspected that there's severe lidocaine toxicity, you should follow the AAGBI guidelines and unblind the participant. And just to note that if intralipid is required, for example in circulatory arrest, don't wait to unblind the participant before you initiate that. All suspected lidocaine toxicity events should be recorded on our CRF form 13, the suspected lidocaine toxicity form, and you should report all events to the UK sponsor at your earliest opportunity, but this must be within 24 hours of the event happening. So I think in a nutshell, just to say that if you do need to stop the infusion, this isn't sort of this doesn't mean immediately you need to unblind. If the patient sort of is stable and symptoms resolve, no need to unblind. That the stopping criteria is there to prevent sort of anything serious happening. If the patient is unstable and sort of symptoms don't resolve, that would then sort of lead to unblinding. So is there any questions about completing the list tool at all?
Yeah, go on.
hypotension is one sign, and in the CRF it says lower than 90 millimeters of mercury. Well,
it's nice.
yeah, it's for the pulse.
Yeah, it's sorry.
And some patients might have normally a low blood pressure. So if this be like a percentage of their baseline, a decrease in their blood pressure, like representing a percentage from the baseline. I mean, if the baseline they have a blood pressure of 110, for example, or 100, 90 wouldn't alert too many people, isn't it?
Mm-hmm.
Comparing to somebody who had a baseline of 150.
Yeah.
So essentially, the goals of the way the protocol's been put together is, number one, simplicity. So they haven't sort of tried to do a calculation of, they're within 20% of baseline. They don't want people to be sort of running around thinking, oh, hang on, is that hypotension or not? You know, if there's a potential emergency. So they've kept it quite simple in terms of having absolute numbers, but also bear in mind, we are excluding patients who are normally quite hypotensive before they go into the trial. I'm struggling to think whether it's a baseline blood pressure of 100 or 110, but basically if they're normally in the 90s, then they're not going to be in the trial anyway. So it is an absolute number, just for simplicity's sake. What I would say is, yes, you might get some people who hit that target and you think, oh, I'm going to need to start stopping things. But the protocol does allow for you to make some simple measures to address that hypotension. So let's say you have got a low blood pressure, the patient is very dry, they might just need a little bit of fluid. It's easily treated, it settles down, that's fine. I mean, the LIST tool really is quite a, it's very, very sensitive. So what it does is give people faith that there's a mechanism to stop the infusion before there's really a proper concern. But when things just don't look quite right in terms of what is being picked up with LIST, that allows people to stop and feel that the trial is being done safely. You know, so it's got quite it's not very specific for lidocaine toxicity. It doesn't wait until things are very extreme. It's just a low barrier for actually stopping the infusion if things don't look quite right, basically.
To clarify, does anyone else have any questions? Yeah. The other thing which I did remember from the meeting prior to this, where I didn't have a trial group time, and I just want to clarify, make sure I didn't get the wrong impression. We do need to, with the symptoms, clarify essentially what is the baseline for that patient, because otherwise that is very low sensitivity if somebody has underlying tinnitus and dizziness or whatever. So, and as Elena's noted, that sometimes that's quite hard to tease out from those patients when they're just recovering from an anaesthetic. Is it best for us to start asking those questions in advance before they come down to theatre? So that at least we have a baseline, or what's your feeling about that, to make sure we're not overly picking up false positives?
So I think it can be done a number of ways. The protocol does not advise asking for symptoms at baseline.
No.
The on-the-ground reality is that we've got one site that tends to like to ask a baseline set of things about tinnitus and funny taste and that sort of thing before they've started. And they have found that quite helpful. They've had some people that have had chemo and maybe just have a bit of a long-term funny taste or tinnitus and so on. So they've found that quite useful. But as I say, it's not in the protocol, and we certainly wouldn't expect it. As far as I'm aware here at Southampton, I don't think they do necessarily ask those questions at baseline. They just rely on, you know, if they are talking with the patient after and they report something. I mean, the hope is that by the time you're asking them the LIST questions, they're fairly with it. You know, they've started their recovery from the general anaesthetic. They're able to converse. So you can say to them, okay, you got ringing in your ears. Do you normally have ringing in your ears? Yes, no, or okay. Yeah. So they can ascertain in the moment if this is a new symptom, basically. But you're right, we are looking for new symptoms. But how you sort of implement that is a little bit up to you. It's a little bit of judgment. And as I say, it can be done in a couple of ways.
Thank you. That's helpful. We need the largest. My reason for indicating some of the recovery staff are really quite junior in this trust. And so I think they're every indication that they want to stop something, they would. And so I think it's important to keep that in mind.
What we would definitely recommend is, until there is good learning from that group on the job, that the certainly your initial patients are very much supervised by the research team in recovery, just while that familiarity builds and they can really get a sense of, okay, when are we stopping these things and when we aren't. I mean, the stoppage rates are actually not bad, even though, you know, if you look across the trial internationally, the list, you know, the stopping rules are actually not that bad. I mean, you are right, you know, it will be quite sensitive, and they will get some stoppages just to think, oh, that was a bit of a soft stoppage, we probably could have carried on. But again, it's about teams having faith in it. You don't want to get your recovery teams a bit twitchy because they thought things were happening that were a bit funny and somebody said, no, it's fine, and then they had a safety event, you know. So you know, it is about building faith in the trial. But yeah, I think in those early days, having it supervised by somebody with a bit more experience is the way to go.
Okay, thank you.
I think honestly, for the scientific value of this study, I think it's stopping it unjustified in recovery. It's so-so. I think what's really bad is stopping it in theaters, because I assume this procedure is taking 1 2 hours, maybe more.
Yeah.
So I think it is really, really good if we don't stop it in theaters.
Yeah, I don't think there should be much indication. I assume from untreated hypertension.
So again, in theatre, you know, obviously it's not symptoms, it is just the signs. A lot of these things happen normally under anaesthesia, and the guidance that's given, and this is in a bit more detail in the anaesthetist training, and also, for example, on the CRF. The CRF is actually, if you print out a full CRF copy, it's got some good guidance notes on the reverse pages. It'll talk about things like hypotension that is out of proportion to what you'd expect, or hypotension that is resistant to normal initial treatment. And the same for bradycardias and so on. So it's not saying that every anaesthetized patient who has a slight drop in blood pressure or slight low heart rate should have the infusion stopped. It's basically saying treat it as normal. If it's not responding, that might get you a little bit suspicious, and that might be the point at which you want to stop it.
Yes.
But the protocol certainly allows for some in-theatre treatment first before you then potentially stop them. So again, we're not seeing many in-theatre stoppages at all either.
Good. Okay. That's great.
Thank you. So yeah, moving on to unblinding. So sort of life-threatening problems where unblinding is required can include sudden unexplained loss of consciousness, tonic-clonic seizure, life-threatening arrhythmia, or cardiovascular collapse. After randomization, you have the ability to unblind on the database for 36 hours. So it's important that if a participant's surgery date changes, that you go into the database and update that surgery date, so you're still able to unblind when the new surgery date arises. If a participant is unblinding, there's a CRF form 11 that will need to be completed, as well as the suspected lidocaine toxicity form 13. We'll provide you with a printed unblinding guideline that you can see on the screen here. So anyone with a account on the database will be able to unblind through that account, but we'll also be providing you with a generic login to the database, which will allow anybody, anybody, even those without an account on the database, to unblind. That is also the quickest way to unblind, so don't feel like you have to use your login and account. Quickest way would be scan the QR code on the unblinding guideline, use the generic login, and unblind that way. So is there any questions about unblinding at all?
No, I just wanted to know what the generic username was going to be, but I guess you'll forward that through. From the training module, it suggests the password should be exactly the same, so we'll just keep it like that.
Yeah, although we have had feedback actually that the password can't be the same, so it might need to be.
Okay.
Yeah.
Okay.
So
fine.
yeah. Haven't tried it ourselves, but one site did flag to us it can't be the same. So I don't know if that was a one-off glitch or whether that is, true. But yeah, so how it'll work is we'll send. It's usually the lead research nurse. So Eleanor, would that be you?
Yep.
Yeah. So we'll send the link with the username, and then you'll just have to create the password, and then obviously write it on your guideline.
Something which just cropped up in discussion, which Maya's just kindly asked about, was if there is an event that happens which was considered about lignocaine toxicity, obviously we follow our local protocol, send off all our local investigations and whatnot. Do you need any other additional investigations from your point of view, from the government's point of view, to make sure this is reviewed appropriately from the trial? And if you did, do you have specific bottles or specific laboratories that need sent to? I strongly suspect that's a no, but I just want to clarify.
Yeah, no, it's a no. There was a sub-study that was being done in Australia with this, where they sent off samples, but I don't think they're doing it anymore, are they, Mark?
No, we're not doing it here, are we? I didn't think it was. I just wanted to clarify.
Yeah.
Thanks.
Fab, thank you. So yeah, continuing with safety. So there's also some safety endpoints listed in the protocol. So a little bit of overlap with that table I showed you at the start of the safety section. So just to highlight that the infusion should be stopped if any of these events arouse cause for concern or can't be resolved following treatment, and they will need to be reported on the relevant CRF forms and adverse event forms. Protocol breaches, so these must be reported on Form 10 and entered onto the Lollipop database. Unfortunately, in the UK, there is also a sponsor required form, which is a paper form called the Protocol Deviation Assessment and Report Form that will need to be emailed to the 2 email addresses you can see on screen now. But just to say, don't worry if you forget one. As long as you report it on one of the forms, we'll remind you to complete the other one. So if you can't remember both, please do. If you do forget, just do it on one and we'll be the reminder to you to do the other one. So there are some example protocol breaches listed in the protocol, but just to note that any deviation from the protocol in the UK is a protocol breach. And yeah, I won't run through them all, but just I guess one I'll pick up on is the open label administration of lidocaine in excess of permitted amounts. If this is picked up before the infusion has started, please don't start the infusion, like the trial infusion, that is, sorry. If it's picked up after the trial infusion has started, then you would need to stop that infusion, because obviously we don't know if that patient's on the lidocaine arm or not.
Okay, I don't think that's a standard of practice amongst the anaesthetists here, but thank you. I will keep that in mind.
Great. So yeah, just in the interest of time, I won't run through all of these forms. You can sort of refer back to them, but yeah, there's just a summary of what events should be reported on each form. And to note, the summary of medicinal product characteristics, or the SMPC, is the reference safety information for Lollipop. And obviously any serious events need to be reported to us within 24 hours of you becoming aware or of the event happening. So yeah, any questions on safety reporting at all?
Not currently, no, thanks.
Yeah, fab. And then my final slide before I hand to Leah is just a note about sort of a quirk with this being an international study. So in the intraoperative data collection form, there's we ask you for dexamethasone dose to be reported. It's actually different, slightly different drugs are used in Australia and the UK. So basically it's been decided that we'll report the Australian dose equivalent. So if you use 3.3 milligrams of dexamethasone sodium phosphate, you should document this as 4 milligrams of dexamethasone phosphate. If you use 6.6 milligrams of dexamethasone sodium phosphate, document it as 8 milligrams of dexamethasone phosphate. I appreciate that's probably confusing right now, but there is guidance on this in our manuals and stuff. And again, if you do forget, it will be flagged as a query. But just something to highlight, you know, if you get a query on that, this is the reason why.
That's fine, thank you. Yeah.
I'm going to hand over to Leah now for the final few slides.
Thank you. So just to summarise the follow-up time points in Lollipop. So we've got 3 time points at 3 months, 6 months and 12 months. The 12-month follow-up is the primary outcome, and we're collecting a patient-reported questionnaire at each of the time points, and then also some data from the medical notes at 3 months and 12 months. Slightly annoyingly, again, with it being an international trial, we're collecting the information on different databases. So all the patient-reported questionnaires are collected via REDCap database in order to allow us to collect these electronically, and then they'll be sort of uploaded by us to the main database. So the only data you need to enter on that side is the medical notes data. If you're not sure what to enter where, it's all detailed in the CRF manuals. We do just say that because the primary outcome is at 1 year, if anyone has not responded to the 3 or 6 month questionnaires previously, we'd still ask that you attempt to collect the follow-up at 1 year. And if they are not responding via email, if you can also try to collect this by phone, that would be really helpful.
Can I ask a question? Showing
yeah,
my ignorance here. Within what tolerance limits do you have of the 3 month, 6 month, and 1 year? So at what point is that? Sorry?
This is window.
Yeah. So what window, just for my knowledge? I know that's more bearing to yourselves with the responses, but like if we got at that, it'd be useful for us roughly to know.
So Chloe, I'm not sure we've got a sort of
I think it's
time frame for the 3 and 6 months, but I know 12 months.
yeah, sorry, off the top of my head, I'm not 100% sure. It's in the protocol if we have one.
I'll
yeah,
check,
but yeah, for the 1 year, which sorry, Lee, I think I just interrupted you, but 1 year I know can be collected up to 15 months post surgery.
Okay. Right.
And in terms of contacting the patient, obviously as many as you feel sort of comfortable to do. Obviously the Australian trial team would say, you know, keep contacting them like we want this data, but as you know, there's a limit to what you feel comfortable.
Okay.
So yeah, we sort of leave that up to you.
That's my ignorance. I should have checked that in the
It's
protocol.
2 weeks. It says on the CRF.
Says on the CRF. Fine.
I think generally we'd sort of suggest sort of 3 attempts is a good rule. But I think that's pretty standard.
Okay.
Okay, next slide, please. So during the 3 and 12 month follow-up questionnaires, participants are asked to calculate their daily dose of pain relief medication. We sort of recognise that might be a bit tricky, so we've developed a participant guidance document which should help out with this. So for patients who are completing the questionnaire online, this is super easy because it's just linked within the questionnaire for them to click on. But just a note for you, if any participants have requested specifically to do the questionnaires over the phone, you will just need to provide a copy of this document in advance of doing the questionnaire. So you can either do that via email if that's an option, or via post. And just to note that you'll need to do that sort of after you've completed a mortality check, but before you do the questionnaire. Next slide, please. Okay, so got a few scenario questions. Chloe, do you think we've got time for this? I'm just conscious that we've only got a few minutes left.
Yeah, we'll try and keep it short and sweet, but yeah, let's go for it.
Okay, so what would your process be if a participant was randomized on the day of surgery, but then their surgery had to be postponed?
Just update the database.
So as the team has said, update the database.
Yeah.
I think I'm thinking of patient focus as well, and explain to them that we can still keep them considered randomized for this trial. I think it's important to make sure that they're aware they are still eligible to be part of a trial if they so wish to, and double check if they feel comfortable to do so. I don't know if that's something you would agree with, but if I was having my surgery there and I was finding it's postponed and I was a bit just challenged by it, then I probably would want to be in part of that decision making.
Yeah, absolutely.
But I'm happy for you to advise me if you disagree with that, because I'm mindful that's just another opportunity to compromise on collection of data.
Yeah, that's fair enough. We do actually say if it's postponed by, I think, more than 30 days, we would need you to reaffirm consent and recollect the pre-op data collection as well. So, but yeah, I think generally that would be a good idea anyway.
And that consent would be in 30 days' time, presumably. You'd get further consent on the day of when they're proceeding, or would you get consent and say on the day and say, look, you've been postponed by a month and a half. do you still agree to consent now, or would you want to? Consent obviously has to be contemporaneous. So would you advise getting consent on the day and then just follow with the previous randomisation?
I think on the day would be fine. Yeah,
Okay.
I mean, we've not actually come across the scenario yet, to be honest, but it's just sort of there to think about just in case.
Right.
But yeah, in terms of like the randomization, so yeah, their allocation would still stand. So you'd still use the vial that they were allocated at randomization. It would need to be continue to be stored. So they can be drawn up on the day of surgery.
Oh, yeah, there's a question from Lisa. Sorry, I'm not sure this one.
Would you that vial that's been allocated at randomisation? Would you want us to quarantine that until the patient comes back, just so we know? I mean, obviously it's not going to be reallocated, but just so we know we've got it separate.
Yeah, I mean, it doesn't necessarily need to be quarantined, I don't think, as long as it's not used for another patient, but it shouldn't be because it wouldn't be allocated to anyone else.
Okay, that's fine.
I think that just on that point, that's why it's quite important to draw up the vial only sort of when you're sure that the surgery's going ahead, because if you had drawn up the vial and then the surgery's cancelled, that patient unfortunately couldn't be re-randomised and reallocated a vial, so they wouldn't be able to continue. So yeah, just to highlight the importance of drawing it up as late as possible.
And would that be a new formal written consent? Sorry, just to clarify, or would you just change the date on the consent form that's already been completed?
Or we just verbally reconsent the patient, just ask them if they have to continue, and we mentioned this.
I think we'd need written, but can I look into the question about a new form or updating the date and put it in your SIV report after? Is that okay?
The main question is, should we redate the same consent form, or you would rather have us doing a new consent one, which would be a bit of a problem.
Yeah, I'm gonna need to seek advice on that actually, because I'm not 100% sure. So yeah, I'll ask and I'll put it as a action and answer within your SIV report.
Okay, thank you. I'm aware we've got less than sort of 5 minutes left in our slot, so I'm just going to sort of speedily run through the rest of the questions. So if a participant had a seizure in recovery, obviously this would be a suspected lidocaine toxicity event. So you'd follow obviously your local processes for resuscitation, and you'd stop the infusion, consider unblinding as well, and then complete all the relevant paperwork for that. So there's an unblinding form, a suspected lidocaine toxicity form, and then the SAE forms as well. Then we've just got a question about what you do if the pump failed during the bolus infusion. So the important thing here is if the pump failed completely, then you wouldn't restart the bolus infusion, you just start from a mils per hour rate. But if it was just an occlusion alarm, that's fine. You just need to check the sighting of the cannula and things. You don't need to sort of restart. And then just a last one on what you do if your participant wasn't responding to the 1-year follow-up questionnaires. As I mentioned earlier, we're just sort of trying to reiterate the importance of this time point really, and just say that if you can try to call them as well as using the red cap reminders, that would be really helpful, and that you can collect this 1-year follow-up for up to 15 months post-randomization. Okay, next slide, please. So just to summarise on how you'll finalise your training after today. So hopefully you've already watched a few of the training videos. It sounds like you have. So you record this on the training log, which is linked there on a QR code, but there's also a normal link. And you record all the videos you've watched, record that you've been to the SIV today. And then once you've done that, you can sign up to Mango, which is where we're having our electronic delegation log. And yeah, if you've got any questions on that, you can email us afterwards.
Yes, Elena's got some questions.
For Mango, everybody needs to go on, and then Alex will have like signing people in.
Yes.
Yeah. Yeah, so the PI has to sign everyone off the site on Mango as well. So firstly, when someone registers, it will come to us to check, and then it will go to the PI after that.
Will we
So-
know when?
Sorry.
Sorry, I interrupted you.
No,
Will
it's
we
okay.
know when he signed it? When we were signed off? Will we receive any
Confirmation.
confirmation?
Oh, yes, I think you receive an email confirmation when it's approved. We definitely do. So
Thank you.
that's yeah. But
You
also
know-
the PI will receive a notification when people register or like are available for him to check. So that's quite useful as well.
Can I also check something really quickly regarding training? There's a member of our team who's not at the SIB today. I think she's already done all the online training, and from what she tells me, she's actually already done like the training log. Does she need to review the training slides that you've gone through today just to finalise the training that she's done, or would you just be happy with what she's done so far without the SIB?
And what was her role in the study?
She's a pharmacy technician. She's the same as myself.
Okay, yeah, she doesn't need to review the slides from today, but obviously she's welcome to if that would be helpful.
Okay. Would you mind sending them across to us? Is that okay?
Yeah, of course, yeah. We will do.
Okay. Thank you.
Okay, next slide, please.
Thank you.
That's just a note to say that we're registered on the Associate PI scheme. I think you already mentioned you've got some more.
Yeah, Maya's
Thanks
already
for that.
registered
Yeah,
through that.
yeah,
I'm
that's
about
great.
to sign her off for that.
Perfect. Next slide, please. And I think we're going to skip through the checklist, but we will send it to you after today, obviously, for you to complete that in your own time. Are there any final questions?
Yeah.
Go on, Elena, do you have any questions? Yeah,
I've got many questions, so.
you go first, Elena.
Okay. We're supposed to give patients some cards
Yes. we
on
are.
discharge.
Some
Will you
documents.
send us those cards? We are doing very bad with printing on this side.
Oh,
say
you
that part of the
want some
CT.
paper copies?
Yeah.
Okay, yeah, that's fine.
Please, yeah.
The approximate date for receiving the pump?
We need MNCA to be signed before we send IMP and the pump. Just to note, we are going through, we've noticed an error on the MNCA, so we're just updating. So we're hoping to get that through as soon as possible, and then we'll send you the updated contract to be signed. Yeah, I'm a bit reliant on the sponsor for that, so I can't give an exact date, but I am pushing for ASAP. So yeah, but we can't send it until the contract's signed.
What is your plan for monitoring?
It's all remote unless there's sort of any concerns flagged, then we might sort of initiate an on-site visit, but it'll all be remote otherwise.
And frequency of meeting?
We don't sort of call, so we kind of do monitoring sort of like period. So we don't have a set meeting. We'll do like periodic, like we'll ask you for a batch of consent forms so we can check over them. If all's fine, we then so I think we do the first 10 forms, and then after that it might be one every 50, just to double check things are okay. And so we don't have a meeting as such. It's if anything was concerning to us, we might call a meeting with you, but there's no regular monitoring meeting.
Okay, because this takes, generally speaking, if you want a monitoring report, it takes one or 2 days of work for me, and nobody's paying for it. So all right. How is data transmitted? Have you got to a conclusion with that? You were saying at some point that you would need ICFs, the consent forms, transmitted to your site. Have you made any plan for this?
So all the trial data, CRF data, is entered directly onto the database. So same with the follow-up questionnaires. For consent forms, it's sent via secure mail.
Okay.
So your trust should have a so we've recently discovered in our trials unit it's different for every trust. So I can't tell you what system you use, but there's
between square brackets.
Yeah.
Okay, that's fine. Okay. Are we all right to do all the? Well, this is kind of a little bit. It's semi-internal. all the record of the research process online on the electronic.
Yeah, I think
So
so.
having no paper.
Presumably, most people are using everything electronically for their,
In-
to their internal.
I assume you don't
documentation.
care too much, really. How we
Do you mean in
Paper
terms of do you mean in terms of site files?
Yes.
Yeah.
Yeah, so it's up to, we don't mandate that, so it's up to you if you want to use electronic or paper.
Anything else mopping up from your side?
I've got just a couple of things. Is there a, forgive me if this is in the training and I've just not written it down, but if there's a problem with one of the vials that's been allocated, is there a way in the system to go back in and reallocate or get a new vial?
Yeah, unfortunately not. So in Australia, they did initially have sort of a spare vial, so you'd have a box of spares and it'll be reallocated. But there hasn't really, I think, in terms of like logistics and costs of that, I think they've used one in 1,063 patients or something. So they've kind of decided it's just not worth proceeding with that. So yeah, so no, unfortunately, there's not.
And that
So I
goes,
can't
and then
damage that one.
and that, no, you can't. And then, but if that is the case, then you log that as a misallocation, don't we, on the trial database? Is that correct? From memory, there's a section where that gets applied. I might be wrong.
Yeah, so it's probably with when you've got your access to the test database. If you go in and have a play with a few scenarios, check you're happy with that, and if not, you know, give us an email or something, and we can run through some bits.
Have you any idea when we'll receive access to the database? I know we've talked about the staging area, but the actual live database.
Yeah, so that's done post green light. So yeah, so the Australian team give the access. So basically, we'll green light you. At the same time, we'll ask the Australian team to give you access. So it will be given sort of the day after because of the time differences. In terms of if you're thinking about sort of IMP receipt and stuff, when we send it to you, we ask for email confirmation it's arrived and you know, no temperature breaches and stuff. And then once you've got your green light access, you can accept it within the database.
Okay, so we might get the IMP before that, is what you're saying?
Yeah.
Okay, that's fine. That's unusual, but yeah, that's fine.
Yeah. I think it's because of the time difference, you know, because usually we might, you know, give you we've got the ability to give you the access, so we're in control of it, but because it's the Australian team and obviously the time difference, they're asleep when we're.
That's fine. It's important to know though, because that's one of the things that we normally wait for to give our pharmacy readiness, but obviously we're not going to be able to do that in this scenario, so I can just make a note of that. It's not a problem. It's just something that's useful to know.
So if the ampule gets damaged for any reason, we just
Then we can't allocate.
We can't.
That's a little bit.
I think that's everything for me. I don't think I've got anything else. There's only a
Do
couple.
you want to clarify that again once more?
Yeah. Just want to make sure if that vial gets damaged, can accidentally just fall on the floor or whatever. What do we do?
So unfortunately, you can't, once the patient's been randomized, you can't then reallocate. So unfortunately, they wouldn't be able to sort of receive an infusion or continue yet.
So we withdraw the patient from the trial.
Yeah. Well,
yes, and protocol breach as well.
Yeah, I was going to say it's a bit. There's a whole thing about the term withdrawal. So technically, it's not a withdrawal, but yes. But I am told the vials are quite robust and they've been dropped and they bounce. So hopefully breakage will be minimal. But yeah, unfortunately, if you did damage one and the patient's already been allocated it, then if you drop it before, you know, if it's broken and it's not been allocated, you can just mark that vial as damaged in the database and it won't be included. It's sort of only an issue if it's been allocated to a patient already and it's broken.
Well, for the study would be useful to continue the follow-ups and to consider that patient as part of the placebo standard of care. But that's up to you.
Yeah, so again, that's in the UK, we would usually do that, but that's an Oz team decision that they're not including them. So yeah, again, bit of a quirk of an international.
Yeah, it's not some strange bloody mindedness on the part of the trial team. Essentially, drug import was a very large cost for UK involvement in the trial. The drug import company considers any product to be anything that has got a different label from something else.
Yeah.
So basically, they see IMP as one product. They see intraoperative vials as one product. They see overnight vials, so that's separate vials for patients who might be staying in overnight, as another product. Spare vials, they saw that as a third product. Every
And day
product
case.
has
Day case
got
made of
checks, costs, day cases, overnight, whatever. They basically got costs, time, etc. And basically they turned around and said, oh, well, there's additional cost of thousands of pounds to check in these spare vials. And the Australians turned around and said, well, we've only used one. So it was a case of spending thousands of pounds for perhaps 1 or 2 patients being lost in the trial. It's a pragmatic decision.
No, makes sense.
Follow the money as usual.
Joe's got questions.
Yep. Come on, Joe.
Joe.
Hi. Sorry, I was a little bit late earlier. Could I? So my name is John. I'm a pharmacist working on this study as well. I remember Alex mentioned earlier about a thermostatic drug cupboard that we're trying to get hold of. I'm just thinking, like, is there anything that the sponsor can support for something like this? About £600. It's not that expensive. I actually got some really cheap ones.
Yeah. Oh, do you want to go, Mark?
That sounds like
So just to reiterate, it doesn't need temperature control. We just recommend temperature monitoring, just for tracking, because the IMP is extremely robust and has been tested up to 40 degrees in the Australian sunshine and doesn't seem to degrade. So it's very robust. We do ask for reports of any deviations above 25 degrees, just so we can see there's not a trend in the wrong direction. I'm afraid we don't have any costs allocated for providing local infrastructure like that, unfortunately.
Okay, that's not a problem. I thought just
we have to try, yeah.
I'm afraid I've just got a couple of things which have cropped up little tiny bits, which are small things. The syringe and the pump, it can be whatever local syringe we use as long as it matches and pairs. There isn't any exclusion for any particular trials other than no, didn't think so. And then
so do you mean they're like a BD Plastipack or a Terumo? The Nexus will take basically anything.
Yeah, as long as the Nexus takes. And then something which I can't find in the protocol. It says attached to a 3-way tap. Does that have to be on a separate line to the rest of the infusions? As in, does this patient need to be cannulated twice?
That's clinician discretion, basically. Some people choose, they find if they're doing TIVA with a vasopressor, there's just too much going on one cannula. They prefer to put in a separate cannula. We don't, drug safety wise, it doesn't need to be on a dedicated line. Compatibility is very good with TIVA and various other things. It could just be that if they're using TIVA and other things, it's just getting a bit crowded on one cannula and they choose to put it on a second. Our stipulation really is just that, it's on a standard non-return valve, so nobody can get a big bolus of it accidentally. But otherwise, compatibility is good. So 1 cannula, 2 cannula, we don't mind.
Brilliant, thank you. I'm sorry, that was just a nice small thing. From the rest of the group, anyone can add any questions?
The study is a portfolio study, isn't it?
Yeah.
Do you know about the press questionnaire, the press surveys?
Press surveys, is that?
Yeah, it's patient experience in research. That could actually, basically we ask patients to complete some surveys to share with us their experience, and those surveys are going to the regional research network, and then they are giving us some feedback. We do use this feedback for our, to improve the quality of what we do, but it might very well fit into future amendments for you guys if you are happy to receive any feedback.
Yeah,
would just be something interesting.
Yeah, I think so.
That's really interesting. Yeah, honestly haven't heard of that. Is that quite a recent thing?
No, been running for 3-4 years now.
As a means of highlighting how things are going with research in the region, and then therefore if there's any issues,
so we
back to the trials.
We have done press for 3-4 years now. And another thing is, you have sent us some posters, among other things. Thank you very much for that. Mm-hmm. Very useful. On the poster, I assume there is a pink place to put probably our contact details of the team. Oh, that's fine. Yeah, there is a space on the top.
Yeah, that's the patient-facing one, is it?
Yes.
Yeah. So as it is, so that at the moment that's just design, but we're submitting a substantial amendment that will allow you to add patient details. So yeah, if you could just use it as it is for now, but hopefully we'll have a localizable version.
Okay.
All right. if it hasn't been approved yet.
No, that one has.
That one.
So
has.
that
Okay,
one
no,
has. It's just not.
I don't manage to pay enough attention to what this says. What I was suggesting on the QR code, patients are seeing the poster. They are scanning the QR code, and then go home, go online, and find out that actually they can see, because I've done it myself. They can see information about the trial, but not how to get in touch with the team. So I think it would be useful to have a link towards your team, to the central team.
Yeah.
Think about it.
Yeah.
Because
I
it
mean,
could be a way of recruiting patients.
yeah. So in the upcoming amendment, there will be a space. So we have added. So it'll be that poster, but there's a space to add the local research team details, so the patient can contact you. So again, I'll have to double check because the website is patient facing. I'm not sure we can add our, we might need approval for that as well to add our contact details. So it is, I'll add that on to a potential for the substantial amendment. But yeah, hopefully in the upcoming amendment, there will be a space to put localization details on there.
Okay. I think this is it for me.
Great. Yeah. Thank you very much for your time.
Great. Yeah. Thank you all. We'll, after this meeting, send around an SIV report that sort of summarises any outstanding actions and things we've discussed today. And then, yeah, essentially, once you've ticked off all those outstanding actions, then we'll be ready to green light you, and we look forward to working with you all.
Brilliant. Thank you so much for getting us involved.
Thank you.
Thanks, everyone.
Thank you.
Look forward to working with you.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Yes, thanks. Bye-bye.
I didn't realize how severely